Thank you so much. At the outset, I would like to thank Professor Dhiman, Dr. Akash, and Dr. Surinder, and whole team of SGPGI for inviting me to deliberate on this topic, which is where the answers are little less as compared to the questions. So this topic is differentiating sepsis and systemic inflammation in severe alcoholic hepatitis patients. So I bring greetings from PGIMER Chandigarh. So I'll be briefly discussing on the concept of sepsis and what is the similarity and dissimilarity with the pathobiology of alcoholic hepatitis, why it is important to differentiate infections, systemic inflammation, and sepsis in patients, why AH patients are prone to infections, what are the real world challenges, is there really a way to differentiate, and what is the proposed approach. There are no disclosures pertinent to this talk. So as a concept, the sepsis lays its foundation with the breach of barriers where the pathogens breaches the barrier and reaches to the systemic circulation and the local site where it leads to local inflammation. And this is defined as invasion of normally sterile body tissues by disease-causing microorganisms, their multiplication and reaction of host tissues to the infectious agents and the toxins they produce. This local inflammation may become dysregulated, and the systemic milieu of immune system, including cells and the circulatory cytokines and the coagulation systems, go haywire and results into the state of systemic inflammation, and which is operationalized with the definition of SIRS, which is defined by fever or hypothermia, tachycardia, tachypnea, or leukocytosis or leukopenia. Finally, this dysregulated state of inflammation can lead to immunopathological damage into the different organs, which is characterized by the definition of sepsis. And this sepsis is defined by the dysfunction by the dysregulated host response to the infection. And characteristically, there are three major components of sepsis, which is the infection, then the dysregulated host response to the infection, and the third is the worsening of organ dysfunctions, which is operationalized with the SOFA scoring by elevation of SOFA scoring from baseline by 2 or more than 2 points. Typical example of infection being the bacteremia, which leads to fever and leukocytosis as systemic inflammation, leading to shock and mechanical ventilation as sepsis. So what happens in alcoholic hepatitis is that there is a impaired liver regeneration, which leads to liver failure. The most important second component is the cell death, which is immunogenic in many forms. And we know that pyroptosis, necroptosis, and phyroptosis are now being described, which are highly immunogenic and incites the liver inflammation through pattern recognition receptors on the monocyte macrophage system and increases the interleukin-8, which actually brings on the neutrophils to the liver. And this liver inflammation spills over to the systemic circulation, leading to massive wide-scale cytokine storm, which includes cellular and soluble components. There is a highly dynamicity in this syndrome where the pro and the anti-inflammatory cytokines are both increased at the initial stages. And the dynamic balance over the period of time will determine whether the patient will go on to death or survival. The third major component of this syndrome, this disease, is the gut dysbiosis, leading to impaired gut GI integrity, which leads to bacterial translocation as well as the fungal elements translocation. And their expression molecules are called pathogen-associated molecular patterns, which again incites the liver inflammation and the systemic inflammation. So in this biology of alcoholic hepatitis, we have, on one hand, there is a cell death, which is leading to inflammation, which is a sterile inflammation. And on the other hand, there is a pathogen or a microorganism which is inciting an inflammation, which is called pathogenic inflammation. And it may be corroborated with the definition of infection that there is a breach in barriers and there is an inflammation. And sepsis, when this infection leads on to dysregulated inflammation and organ damage. Whereas on the other hand, there can be sterile inflammation because of DAMPs. So how to differentiate between all this stuff? Adding to the heterogeneity, alcoholic hepatitis can present in different shapes and forms. It can present with mild alcoholic hepatitis, severe alcoholic hepatitis, with acute decompensation, with ascites, HE, GI bleed or infection, or it can present with organ failures. On top of it, the patients can have first-time presentation without underlying chronic liver disease with the APASL-ACLF. Adding more to the heterogeneity of presentations and disease biology, the alcoholic hepatitis can present at different stages of underlying chronic liver disease. And we know underlying chronic liver disease will lead on to cirrhosis-associated immune dysfunction because of ongoing pathogenic bacterial translocation, which modulates the immune system. So such a high heterogeneous state, and how to differentiate between the infections and non-infections in this syndrome. So systemic inflammation, we know that it is quite common in patients with alcoholic hepatitis. And what is its significance? So systemic inflammation, as seen in this study by Batala's group, around 46% of patients had systemic inflammation in form of SIRS at presentation. However, only 30% patients had evidence of infection in form of clinical or microbiological. But the 70% of patients were not identified to have any infection. And in this group of patients where there was no demonstrable infection, the possibilities of occult infection or the sterile infection because of DAMPs was considered. So what was the significance of this systemic inflammation? Systemic inflammation in the form of SIRS led to higher mortality and poorer survival at the end of 90 days. And when they looked at the association of infection with SIRS, they found that when the infection was there, it did not differ the outcomes. That is, the presence of infection or no infection at the admission did not have any impact on survival. Rather, only the SIRS was the important determinant of outcome. When they looked at the infections, whether in hospital or at admission, they found that in-hospital infections were significantly associated with poorer survival. So probably the infections which were there at admission were adequately treated and did not confer the poor survival. Whereas, how did systemic inflammation lead to poorer survival? It was not a direct association. The association was with the multi-organ failures. And we all know whenever there is a systemic inflammation, it drives basically the multi-organ failures and which leads to mortality. This concept of systemic inflammation has also been looked in the ACLF group of patients from the canonic study. There they showed that the SIRS was present only in 15% at admission, and this was associated with poorer mortality about at 30 and 90 days. And the greater systemic inflammatory markers were seen in patients with bacterial infections and alcoholic hepatitis patients. So whether this systemic inflammation precedes the infection, the answer was given by an elegant study by the Dr. Sarin's group, where they showed the patients with APASL-ACLF without any prior decompensated chronic liver disease. They followed up these patients without SIRS, and fitting into definition of APASL-ACLF, they found that over the period of 7 days, around 56% of patients developed SIRS. And out of these patients who developed SIRS, they had higher incidence of sepsis. And those patients who developed SIRS at day 7 had a poorer survival. And those patients who had SIRS to start with and persisted at day 7 were also having poorer survival. So summarizing the findings, that the patients with alcoholic hepatitis presenting with either with severe alcoholic hepatitis or with ACLF, presence of SIRS will modulate their organ failures and mortality. And the incidence of infections is shown higher in patients with SIRS. So why patients with alcoholic hepatitis are prone to infections? And we know that there is multitude of immune defects in these group of patients. Starting from the neutrophil, monocyte, macrophage system, although there is a dichotomy that they are secreting more number of pro-inflammatory cytokines, their functions are going down. Their phagocytic functions are going down. And recently, epigenetic changes have been described in this group of patients, where they showed that polyclonality or the polyfunctionality of neutrophils and the monocytes were grossly impaired. That is, by the stimulation of PAMs, they were not able to stimulate the more than one cytokine, thereby meaning that these monocytes or the neutrophils in patients with alcoholic hepatitis are grossly defunct and they are not able to clear PAMPs or DAMPs. Thereby, they are just secreting the cytokines and causing the immunopathological damage. And in patients with alcoholic hepatitis, as the severity increases, the functions go down and the systemic inflammation increases, and the incidence of bacterial infection also increases at the same time. And using corticosteroids in patients, especially in the state of inflammation where there is a lot of immunosuppression, the immune cells express the co-inhibitory molecules such as PD-L1 as well as TAM receptors. They tend to have a poorer phagocytic functions. And those are the group of patients in whom, if we give corticosteroids, they lead to opportunistic infections. Therefore, in different studies, we have identified that the infections are quite variable in patients with alcoholic hepatitis, ranging from 12 to 50%. And this difference is probably because of differences in screening strategies, as well as the use of antibiotics at different centers. From the STOPA trial, it was shown that the baseline prevalence of infection was 12%, and while they were on treatment, it increased to 23%, and after treatment, it was 8%. And steroids led to serious as well as the post-treatment infections. Bacterial infections, although are more common, but the fungal infections are very, very important cause of mortality, especially in the nosocomial setting. So how does infection leads to poor outcomes? In this seminal study, where in the PREDICT study of patients in which they took acutely decompensated cirrhotic patients, where the alcoholic hepatitis patients was the dominant etiology, and they showed that patients with AD, no ACLF, as well as with ACLF, the severity, the mortality of patients with alcoholic hepatitis, as well as with those with bacterial infections, were similar. And when they looked at the number of precipitants, they found that the combination of alcoholic hepatitis and the bacterial infection led to poorer outcomes, both in acutely decompensated as well as in ACLF group of patients. And when they looked at the patients, the role of antibiotics in these group of patients, so they found that those patients who have demonstrable infection and were treated with adequate antibiotics, there was an improvement in survival. On the other hand, if these group of patients with acute decompensation and are not treated with adequate antibiotics, it led to a poorer survival, both in acutely AD patients as well as in ACLF patients. Meaning thereby we have to identify the infections early on and treat them adequately to prevent the mortality in these group of patients. Another example, not from the alcoholic hepatitis group of patients, but from SBP in patients with cirrhosis who presented with septic shock. In this study, they showed that each hour delay in antibiotic increased the odds of death by 1.86 times. So adequate antibiotics, early antibiotics in patients with infection is highly important. But how to identify this group of patients early on is the main question.
Dr. Nipun,
yes,
your time is up. Can you just summarize? Sorry for the interruption.
Give me 1 minute. I'll just briefly discuss the concepts. And as we know that fungal infections are also very increasing in these group of patients, close to 14% in ACLF, and their mortality is quite high, especially 76% higher than the bacterial infections. So how to identify these group of patients with sepsis? Sepsis systemic inflammation. Systemic inflammation is identified using SIRS criteria, but SIRS is more of a tool of prognosis, and which is leading to multi-organ failures. It's not a diagnostic criteria for systemic inflammation. Individual component does not convey the prognosis. The fever can be altered by use of steroids, existing immunoparesis, or can be because of drug fever. Heart rate can be modulated by hyperdynamic circulation, beta blocker use, or the presence of cardiomyopathy. And the tachypnea can be because of tense ascites, pleural effusion, HE, and leukocytosis can be because of sterile inflammation, or leukopenia can happen because of hypersplenism or drug-induced cytopenias. And various markers of systemic inflammation are not widely available. How to diagnose infections? As of today, we have clinical, radiological, and biochemical and culture-based methods. but these are often inaccurate, and we need biomarkers for identification. Definition of sepsis includes the worsening of SOFA scores, and which we can use, but presence of ACLF per se because of alcoholic hepatitis will lead on to a lot of confusion. We have different defining criteria for infection by NACSELD group as well as EASL group. They are easily applicable, and they include the clinical, radiological, as well as the microbiological criteria. Different biomarkers have been studied, including CRP, procalcitonin. Although their accuracy is limited to 70 to 80%, but the procalcitonin has recently been shown that according to the level of bilirubin, we can use a higher cutoff for ruling in the diagnosis, which is the 0.94, and 0.5 for ruling out the diagnosis. And biomarkers for fungal infections have also been studied in the form of beta-D-glucan by our group with an accuracy of 77% and 74% respectively. Recently, new markers have been developed in patients with infections for diagnosis of infections and cirrhosis. And CD163 is a very important example, which is a macrophage scavenger receptor present on the monocyte macrophage system. And if it is present, it prognosticated the outcomes as well. And in this important study by APASL-ACLF group, the presence of infections, the CD163 levels and the mannose receptors level were significantly higher in patients who were infected. That CD64 is also an important biomarker. And then various profiles of systemic inflammation can differentiate. The cell death biomarkers can also differentiate in the form of RIPK3 between infections and non-infections. Bacterial DNA can differentiate the onset of infections after steroid therapy. LPS levels can differentiate the presence of infection in hospital. MPO, the monocyte oxidative burst, can differentiate infections in cirrhosis. IL-6 can be used. Recently, metabolomics have been used. And there are different other biomarkers which are still needs validation. And different microbiological advances are in process under investigation. Finally, my algorithm for treatment of patients with alcoholic hepatitis includes, if they present with SIRS, we rapidly assess for infections, localize the signs and symptoms of infection, and identify organ dysfunctions and organ failure as well as CLIF SOFA scoring system. Send the cultures and investigations, and the infections is suspected, we start antibiotics within 1 hour. And this is as per surviving sepsis guidelines. If there is organ dysfunction or organ failure, we start antibiotics early on. If the infections are ruled out, steroids can be used, but bacterial DNA is recently shown to be a helpful tool to use steroids in patients with alcoholic hepatitis. Whereas in patients who do not have SIRS, standard methodology of assessment followed by ruling out infection and initiation of steroids can be applied, and antibiotics can be started in patients who have organ dysfunction or organ failures. Finally, we need to reassess every 48 to 72 hours and de-escalate as per the microbiological report and the stewardship protocols. Thank you very much.